will welcome you all in another YAVA cardio risk wave. This is the wave number 6, and today with me Dr. Ahmed Shawqi Sarafi, Professor of Cardiology at Shams University, Dr. Abdel Shafi Tabl, Banha University, and Dr. Tamer from Zakazig University. I will leave the stage now, or leave the microphone to Dr. Abdel Shafi to introduce the agenda of the meeting. Dr. Abdel Shafi, تفضل.
بسم الله الرحمن الرحيم. شكرا دكتور اشرف. النهارده يعني عندنا اجنده دسمه جدا طبعا كالعاده. عندنا تو توبكس. فيرست توبيك ويز بروفيسور دكتور اشرف رضا هيكلمنا عن نيو ابديتس ان هايبرتنشن جايد لاينز، وحقيقه هيكلمنا عن حاجه يمكن فيري ريسنت، لسه يمكن الشهر دوت نازله، ان في ريليشن شيب جديده جدا بين الراس سيستم بشكل عام والايس انهبيتورز اند اي ار بيز بشكل خاص مع الكوفيد 19 انفكشن اند تريتمنت. وهنشوف دكتور اشرف هيكلمنا عن الموضوع ده، وبعد كده هيبقى معانا دكتور احمد شوقي الصرفي ويز كيس ديسكشن عن عيان hypertensive patient in high risk. Let's start with دكتور اشرف رضا. اتفضل دكتور اشرف.
Thank you, Abdel Shafi. It's nice to have you with us, Dr. Shawqi. Welcome, Ramadan Kareem. Well, let me introduce the presentation of today. Half of the presentation will be about some points in the hypertension guidelines, and the other part of the last part will be focused on RAS inhibition in the era of COVID-19. Actually, there is no major changes in the guidelines of hypertension. The most recent one nowadays we have is the ACC/AHA and the NICE guidelines. I will try to highlight some points which I believe it should be key messages in the management of hypertension patients. I think the first key message is that when we are treating hypertension, we should assess the cardiovascular risk as a whole. It is not a matter of just managing a blood pressure number, because the patient with hypertension is a high cardiovascular risk patient. He may have other comorbidities, dyslipidemia, diabetes, chronic kidney disease. So the first step in the evaluation in order to do a proper cardiovascular protection is cardiovascular risk evaluation. And I will tell you now in a minute how this cardiovascular risk evaluation can dictate the management strategy, the threshold of treatment, and even the goals of therapy. So I think every one of them should use any of the risk scoring chart. I will reduce the image of the risk scoring chart to assess the cardiovascular 10 years atherosclerotic cardiovascular disease risk. Other part is that there must be a clinician-patient discussion about the different strategies of management. You have to convince your patient why you are treating him and what is the goals of therapy. Discuss the various drugs for his conditions, and the patient must be sharing with you the decision-making in choosing the proper treatment in order to enhance the compliance and the adhesions of the patient. One important factor is in view of the risk stratification, there is some data using the risk-enhancing factors and calcium scoring to help you in the guide decision about the preventive intervention and the hypertension. For example, if you have a patient with mild risk, for example, you can, and you are hesitating to be aggressive in risk factor intervention with this patient or not, you may use calcium score, you may use ultrasound of the carotid, ultrasound of the femoral, some laboratory work like high sensitive selective protein. This can help you in putting the patient in appropriate risk category and decide whether to start early treatment with hypertension, whether the threshold of treatment should be low if the patient is high risk, for example. One of the important key message in the last guidelines of treatment hypertension or cardiovascular prevention is focus on the non-pharmacological intervention, like exercise, like smoking. Another important part is that there is much differences in the target of treatment. And I want to tell you that the target of treatment is important, but more important that keeping the risk of the patient low, keeping the blood pressure always below the target. It will not make a big difference 140 over 90 or 130 over 80. However, the ACC guidelines replace 140 over 90 by 130 by less than 130 over 80. So actually the concept of cardiovascular protection should be with you while you are treating a patient of hypertension. That's why we should, in addition to the choosing the hypertension drug therapy, you should concentrate on lifestyle intervention. You should ask yourself whether your patient is indicated for aspirin or no. I know that aspirin in primary prevention is now downgraded, especially in the elderly, especially in the low-risk population, especially if there is high risk of bleeding, because the benefit of it is less than the harm in certain situations. Statin therapy is also important. This is 3-point lifestyle intervention and aspirin and statin. Lifestyle intervention, of course, exercise and food. The most important recommendation regarding exercise is at least 150 minutes per week, moderate intensity physical exercise. Regarding the food, actually, actually there is change in the concept of food and healthy food and healthy diet in the last few years. However, the most important part in if I wanted to give you a key messages regarding the recommendation regarding diet and food, first of all, you have to control the total caloric intake in order to keep a good weight and reducing the weight to the optimal one. Second of all, the most dangerous type of food regarding cardiovascular disease is sugar and carbs. I don't want to say that fat is okay, but healthy fat is okay. Healthy fat like egg, like olive oils, like avocado, like nuts. This is healthy fat, which is okay, and it's much safer than carbohydrates and sugar. So you have to keep weight and weight reduction. If it is increased, increase your vegetables and fruits, and decrease as much as you can the amount of carbohydrates and sugar per day. Another important part is the smoking, and you should give time to discuss with your patient to help him in to get rid of this addiction, very serious situation. The last point in the lifestyle intervention in the cardiovascular protection, rather than the blood pressure treatment, is whether your patient will be benefit from aspirin or not. Low dose aspirin, actually, when it is indicated, if your patient is at high atherosclerotic cardiovascular disease and he is below 70 years, and even in this situation, it is only class 2B. 2B may be considered. However, aspirin is even low dose is harmful and may be contraindicated as a routine use in primary prevention above 70 years of age. Also, low dose aspirin is contraindicated and harmful in primary prevention of atherosclerotic cardiovascular disease لو البيشنت عنده increased risk of bleeding. So actually, as I told you in the first, it is downgraded because you are giving the patient statin, you are giving the patient good protective antihypertensive drugs. So the amount of benefit we left for the aspirin is actually very low. That's why assess the risk of bleeding, the age of the patient, and the cardiovascular risk to take a decision. Statin is also important. Even most of the hypertensive patients has a lot of other risk factors like obesity, maybe metabolic syndrome, borderline glucose intolerance, or even diabetes. So that's why statin is very important most of the diabetic patients, most of the patients with high scoring atherosclerotic cardiovascular disease will need. So again, the number 130/80, 140/90. You know, in the COVID era, we are noticing political interference in the decision making in the cardiology. Most of the political leaders become physicians and advise with these drugs or that. So I think regarding the numbers, it is whatever the USA say it is 138, others says it's 139. This is not the issue. This is not the problem. The problem is cardiovascular protection. The problem is keeping your blood pressure below the target rather than looking at a certain target, actually. That's why measuring of the blood pressure is important. And actually, there is a change in the concept of measuring blood pressure in the last 5 years. For example, most of the guidelines in 2013 were depending on office blood pressure to dictate the threshold of treatment, the goals of therapy, follow-up of the patient. However, nowadays, it is not only office blood pressure. The recommendation is repeated office blood pressure is important, and out-of-office blood pressure measurement, ambulatory, the home blood pressure monitoring is very important. And that may explain why, when you look at the clinical trials and the recommendations of 140/90 or 130/80, ask yourself, what was the type of measuring blood pressure in these clinical trials? Because if they are using office blood pressure, it differs from using ambulatory blood pressure or home blood pressures, and that's why the difference in number is there. And if you look at most of the guidelines regarding the drug therapy and choosing of drug therapy, we have some observations. This is, for example, the GNC8 as an example of algorithm for hypertension management. Of course, they depend, first of all, if your patient has diabetes or chronic kidney disease, this is an algorithm. If no diabetes, chronic kidney disease is algorithm. And whatever the situation, you have to see if your patient is above 60 or below 60 regarding the goals. Here, it was 140/90 for all, and even GNC8 for above 60, they put a relatively higher goals of therapy, less than 150/90. But I think this is changing in the NICE and in the ACC guidelines. Most of the treatment algorithm include thiazide, ACE inhibitor, ARBs, or CCB, alone or in combination, whether the patient diabetic kidney disease or no diabetic, no kidney disease. And even if this combo is not working, the next step is to increase the dose of medications and maybe put aldosterone antagonist, and lastly, beta blocker. As you know, in the last 10 years, it is down-regulated in the management of hypertension. Most of the guidelines focus on the use of single pill combination, which may contain 2 or 3 drugs, because this is effective strategy, safe, cost neutral, and improve the compliance and adherence of the patient. And even the WHO now put the single pill combination on the essential drug list of the WHO. So it's facilitate the management of hypertension, putting in mind that most of the hypertensive patients are high-risk groups. There is other risk factors, and maybe he can start with combination therapy even from the start, not waiting too long to start combination. Okay, that was the ACC/AHA. If you look at the NICE or NICE 2019 recommendation, this is the main points of these guidelines. Lower threshold of treating stage 1 hypertension if the 10 years risk score is high, more than 10%. So start the treatment early. If the risk of the patient is high, don't wait. Don't try lifestyle for 3 months or 6 months or 9 months. So long your patient is high risk of cardiovascular risk, why not start early as possible treatment hypertension? Patient preference in discussing the drug treatment is very important. This is important. The third message is very important. consistently maintain your blood pressure below the target rather than aim for a certain target. ايه الفرق يعني ايه الكلام دوت؟ يعني it is not just important to look at your for example blood pressure of the patient. If it is 150/90 or 145/95, you tell yourself, okay, this is it's okay, this is above the target by minimal numbers, so we can keep the same treatments and waiting for another 2 or 3 weeks. No, it is very important to consistently maintain your blood pressure below target. This is very important. They maintain the same 140/90 target goals of therapy. Asymptomatic severe hypertension, this is important recommendation. 180/120, for example. No need for urgency or emergency, so long there is no target organ damage. You can still manage this patient at outpatients. No need for emergency consultation or emergency hospitalization. Special طبعا recommendation for the diabetic patient. So the main therapeutic approach regarding hypertension: single pill combination, thiazide-like CCB, RAS inhibition, ARBs, spironolactone, and lastly beta blocker. So RAS inhibition actually is the most widely used treatment in management of hypertension patient, and that's why we have some data about the relation of RAS inhibition and the corona or COVID-19 interaction and virus. What is this relation? Why it is important to discuss these relations, and what should be as the recommendation for our patient during the pandemic of COVID? If we look at the this diagram, this is actually this is the ACE2 receptor. ACE2 receptors angiotensin converting enzyme 2. This is a good receptor and a good pathway usually. It is the pathway of angiotensin 1-7, which cause vasodilatation, which cause good remodeling. However, unfortunately, these same receptors is the pathway through which the virus of SARS-CoV-2 can enter inside the cells and replicate. And you know that if you are taking ACE inhibitor and ARBs, there is upregulation of this ACE2 inhibitor. So the first claim now is that maybe ACE inhibitor, ARBs, can facilitate the entrance of the virus inside the cells. This is one side of the coin. We have to look at the whole picture, because we have evidence that the COVID-19 virus activates the angiotensin 1, angiotensin 2 system, which is the bad guy here. And there is explanation that the pathological mechanism behind the multi-organ failure in COVID is through the activation of angiotensin 1 and the 2 system, and through the downregulation of this ACE2 inhibitor. So the other type of the coin is that if you are using ACE or ARBs, you are counteract the main pathological mechanism of COVID-19 for introducing or inducing multi-organ failure, pulmonary cells on the kidney, myocardium, and remodeling. So if we look at this important paper in the New England Journal of Medicine about the key point related to the interplay between COVID-19 and the renin-angiotensin system, the main conclusion is that until further data are available, we think that RAS inhibition should be continued in patients in otherwise stable condition who are at risk for being evaluated for or with COVID-19. If there is some study about in this regards, yes, there is one retrospective. It is retrospective, but it is the available one. Multi-center study in Wuhan, more than 1,000 patients, published recently. Patient without ACE or ARB, and the other arm is with ACE ARBs. Unadjusted mortality rate was lower in the ACE ARBs group. Patient with COVID-19 having ACE ARBs, there is lower mortality than those not receiving ARBs. So the result consistently demonstrated lower risk of COVID-19 mortality in patients who received ACE ARBs versus those who did not. This is a retrospective study. It is not prospective, randomized, placebo control. However, it gives us some idea. And until now, most of the hypertension society recommendations, like the EHS, ESC, ACC, Canadian Society of Hypertension, the American Society of Physicians, stated that to do not stop ARBs or ACE inhibitor in hypertensive patient infected with COVID-19 because there is no evidence of harm. And now another open study in Europe and USA called REPLACE study, the randomized study is running for the same issue in hospital treating COVID-19 patients. In the same concept, what about neprilysin inhibitor angiotensin II receptor blocker combination? There is a nice recent paper in the European Heart Journal in this few weeks ago about the use of neprilysin inhibitor angiotensin II receptor blocker combination, sacubitril, valsartan, في SARS-CoV-2 patients, whether it is useful or not, especially if the patient is heart failure and is. And the recommendations or the conclusions of this study is that the virus itself downregulates the ACE2 receptors, thus increasing the angiotensin II, the bad guy, and reducing the good guys, increasing AT1-mediated pulmonary permeability and lung injury. So valsartan upregulates the ACE2 receptor and may protect the lung injury and block the angiotensin II through AT1 receptor protecting mechanism. Not even that, even neprilysin, which is inhibited by sacubitril, reduce the inflammatory cytokines and C-reactive protein and lymphocyte. So this piece of evidence support the use and no problem in using sacubitril valsartan early in COVID-19 patient, especially with heart failure. So I think in the end of my presentations, I can conclude that assessment of cardiovascular risk is very important to guide the timing of surgery, the threshold of treatment, and even the goals of therapy in hypertension patient. Comprehensive cardiovascular prevention, it is not only blood pressure management, lifestyle intervention, statin, blood pressure treatment, special consideration, diabetes mellitus, chronic kidney disease, and high cardiovascular risk, the importance of single pill combination, the ACE are interest to be continued in COVID-19 era. I think I can leave the mic for my colleagues for discussion after the end of this session. We have half a minute or a minute of break, and then stay with us for the discussion and conclusion.
Thank you, Dr. Ashraf, for the book. حقيقة أنا عندي 2 short questions لحضرتك. حضرتك قلت لنا إن النايس جايد لاينز اللي هي most recent guidelines in hypertension قالت مهم جدا إن إحنا not stick to the target. We have to below the blood pressure under the target. So my question is for which limit below target وهل ده ممكن يبقى for all patient including the very elderly patient؟ ده first question for me. The second question حضرتك قلت لنا ان الاس inhibitor and ARBs اللي هي very important for many cardiovascular disease زي الهارت failure, ischemic heart disease لها two sides of coin. One side with COVID-19 era, one side have a beneficial effect to block the angiotensin 1, angiotensin 2 vasoconstrictive effect and the pro-inflammatory effect. This is a good benefit, and also have harmful risk that increase the ACE2 receptor. وحضرتك قلت ان في اليوهان ستادي كان في conclusion ان الجروب patients that receive the ACE inhibitor in a treatment strategy for heart failure كان لهم good outcome with COVID-19 disease. فاللي انا عايز افهمه هل دلوقتي ال ACE inhibitor and ARBs beneficial or risky in such patient with COVID-19 واف عليها question لو في question على التريتمنت دي هل ده excuse لينا ان احنا نبدا الارني كانيشال ثيرابي فور هارت in this time يعني هم دول السؤالين اللي عايز اسالهم لحضرتك.
طيب هو شافي الحقيقه اول سؤال بالنسبه للتارجت اوف ثريشولد، اهم حاجه ريكومنديشن واضحه دلوقتي ان انا دايما ابقى keeping below ال 140 90 or 130 80. ما اسمحش بالتجاوز فوقيها وابقى مطمئن وعشان انا قريب من التارجت، لا لازم انزل تحت، لان الجايد لاينز بتقول لنا should be below 140 over 90 or below 130 over 80. وطبعا بتفرق ان انا بقيس الضغط لو انا في العياده انا رايي استخدم 140 over 90. لو كان امبولاتري بلاد بريشر او في الهوم بلاد بريشر استخدم below 130 over 80. لحد below لحد كام طبعا بيتوقف على الايج اوف ذا بيشنت، tolerability، السيمتومز بتاعته. So long the patient is asymptomatic, he is doing well, I think no problem in keeping blood pressure. It is not like statin, the lower is the better and the even lower is even better, because sometimes the very low blood pressure is harmful, especially in the elderly patient, especially in patient with unstable coronary artery disease. So you have to beat the picture. So خير الأمور الوسط, keep below the target but not very low. This is the question one. Question two, ACE and ARBs and COVID. I put some explanation of the mechanisms of entrance of the virus inside the cell using the ACE2 receptors. And I put on the other hand, why multi-organ failure with COVID is related to hyperactivity of the angiotensin system and down regulation of these ACE2 receptors used by the virus. The theoretical speaking is put a theory. It is a theory. We depend on clinical trials. The evidence we have till now is using this drug is beneficial, not harmful. And the recommendations of the Hypertension Society is to continue the drugs, no problem. On the other hand, we are waiting for a randomized clinical trials to confirm the benefit shown in the Johannes retrospective study. So I think we have to follow the last recommendation of the societies that no problem in using ACE or ARBs. Of course, interest to neprilysin whenever indicated, whatever the pathological background of this relation between the virus and the ACE2 receptor.
دكتور أشرف.
بسم الله الرحمن الرحيم. ان شاء الله هنبتدي الجزء الثاني من الويبينار الجميل النهارده اللي ابتدى استاذنا الدكتور اشرف رضا في الجزء الاول. استاذ الدكتور احمد شوقي هيكون معانا في الجزء الثاني، هيكون كيس ديسكشن مانجينج هايبرتنشن ان 2020. ان شاء الله الكيس ديسكشن دي هيكون مصحوبه ب كويشنز وهيبقى في فوتنج موجود عليها، وده هيدي الكيس ديسكشن مزيج من الاثاره وهيكون شيء ممتع باذن الله. اتفضل دكتور احمد ابتدي ان شاء الله.
Thank you, Professor Tamer. Thank you, Professor Ashraf. Thank you, Professor Mohammed. It's always a pleasure. I'm welcoming all the attendees, and I cannot stress enough, try to vote. We want to know what we're thinking. It's not a question or answer for a prize. It's how we manage our patients. And why 2020? Because actually last month or the month before it, the International Society of Hypertension published their guidelines too, and some slides I have for you today to discuss how to manage. So this is a case. It's a simple case. A 57-year-old male who's a smoker. He is not complaining, just some shortness of breath. He is a little bit overweight. He's not obese. His body mass index is 27. And his blood pressure repeatedly is 150 over 100 in both upper limbs. His heart rate is 70. And this is our case. Just shortness of breath, 57, smoker, no other risk factors. My first question, when you're treating hypertension, when you're treating any disease, is it just for control, for numbers, or are you also trying to reduce the target organ damage? Or are you assessing and controlling the risk profile of the patient? or all of the above? Please answer the question, and we'll see what we can discuss. Of course, Professor Ashraf has a lot of nice slides, and he gave a lot of answers. So try and remember his excellent lecture. It will have a lot of info in this.
في بول معاك دلوقتي يا عم؟
I cannot see anything, Montez. Okay, there is a vote. We want to keep the vote as many as possible. We need maybe 8 or 10 seconds. Don't take it much longer because we want to continue. I cannot, no.
Okay, you can comment, Ahmed.
Okay, this is very important to take into consideration. Professor Ashraf, you're live, right?
Yeah. With you.
What do you think, Ashraf? Would you like to do all?
I think this is summarize the concept of management of hypertension in most of the guidelines. Because okay, the poll, Ahmed, this facilitates your message.
Perfect. So please, Professor Ashraf, continue. I'm sorry that I stopped.
So I think it's very important for all of us to know that our aim in treating hypertensive patient is to prevent cardiovascular event and cardiovascular complication. And could not be achieved with just the blood pressure management. You have to control all the other cardiovascular risks and diabetes, dyslipidemia, smoking and lifestyle intervention, and so on and so on.
Okay, so perfectly said, because we know mortality in the world is headed by cardiovascular disease, and the number one risk factor for mortality worldwide. And now, I'm not talking about 2004, I'm talking about now. It's nearly 10 million causes of death due to hypertension by itself, regardless if the patient is in a high social standard, moderate, or low. And even our data from Egypt that was done in the 100 million healthcare and showed that nearly 20% on average of Egyptians headed maybe by Bursaid, and Professor Atif al-Bahari will not be happy about that. And then Cairo and Alexandria, we have a lot of hypertensive in our adult population. And we know that the risk factor of hypertension is the target organ damage, be it the brain, the abdomen, in the lungs, be it the heart, be it the eyes. Very important that we should take care about that. And we know that in Egypt, because if we're thinking that Egypt's data is different, no, we're still the number one cause of death are coronary heart disease and stroke. But the biggest problem in our country, in the hypertensive patients, the mortality rate for cerebrovascular strokes, the mortality rate for ischemic heart disease is quite much higher than those in the counterparts in the Middle East and also in the countries. This leads us to what is hypertension. Of course, we know the European guidelines of hypertension said what is optimal below 120 and 80, and I think all guidelines agree. And there is the grade 1 hypertension, grade 2 hypertension, grade 3 hypertension, increasing by 20 systolic and 10 diastolic between each grade and that. But the American guidelines in 2017 were a little bit aggressive. Of course, normal was below 120 and 80, but stage 1 hypertension started not at 140, at 130 till 89. And stage 2 is above 140 over 90. So stage 1 hypertension in the European guidelines is actually stage 2 hypertension in the American guidelines. And of course, we've seen that, of course, there are other methods to manage and follow up blood pressure. And again, Professor Ashraf just said this, that there is a lot now on talking about using other ways of measuring the blood pressure, like the ambulatory or the home blood pressure. And the office blood pressure management that you think is very simple, I just give you this picture. This was just published a month ago, and we think it's a simple picture. Actually, this picture talks a lot. We need the patient sitting correctly, not talking during or between measurements. The cuff size is correct. The cuff and the blood pressure measuring apparatus must be validated at the same level of the heart and in a quiet room without any smoking with an empty bladder. You can think that this picture is very simple, but actually this picture, look at the way to measure the blood pressure correctly. And I hope we can do this, and we have to measure the blood pressure in both arms to make sure of our patient and do follow up the way to do it. Out of office measurements, of course, they do have their advantages and disadvantages. Of course, the ambulatory may not available in a lot of situations, but the British guidelines or the NICE guidelines advocate that all patients must be measured by white coat or mast hypertension very correctly, because they measure around the 24 hours. The whole blood pressure also helps us a lot, but it does not show the sleeping rhythm or the sleeping blood pressure. So again, we go to our patient. I remind you, he's obese, hypertensive, grade 2 hypertension in the European. Of course, in the American, they're all grade 2 hypertension. And we're going to do an investigation for our patient. We have several investigations in the cardiovascular continuum. For you, please vote. Which one do you think is not essential? I'm not saying it's not important, but if you don't do it, you didn't do a big problem. Is it the urine analysis, the echocardiogram, the uric acid, or the TSH levels? So please vote.
I think the results will be important. Many physicians, all of this,
and much more. Yes,
and much
actually,
more. So it is nice to see which of these measures is not very essential in the management of hypertension.
Exactly. I'm not saying they're not important. All of them are important. All of them can be
not
done.
Necessary.
Exactly. It's not very necessary, because sometimes
أعتقد يا أحمد إنه كله إن إحنا كان ممكن الاختيارات يكون أفضل. مين منهم هنفكر في الاسينشال هايبرتنشن ما يكونش بيزك في الأربعة دول. يعني في واحد منهم هيكون في السكند هايبرتنشن أكتر من الاسينشال.
Very good point that we're talking about primary and secondary hypertension. Great برضو idea. I'm waiting for the results.
في results يا معتز معانا؟
And we're getting the results. This is really important to think what everybody is thinking. Actually, it's not a Bible or the Quran. There are, according to different situations, availability, pricing, there's a lot of difference between different investigations and others. So actually, there is no 100% correct answer. There is no incorrect answer. We just...
Professor, so Ahmed, for example, till the results is clear, what is the importance of urine analysis, for example?
It's very important. You do not need a full urine analysis. You can just have a urine analysis with a dipstick to see if you have albuminuria, which is target organ damage in hypertension and diabetes. But of course, if you do a full urine analysis, you can get a lot of that if there's infection.
I have some results, Ahmed.
Please.
66% uric acid and 33% for urine analysis.
Okay, this is good. Today we're having a nice day. Okay, let me go to the next slide. Okay, and this is the routine by the ESC guidelines. Hemoglobin, blood sugar, blood lipids, blood triglycerides, potassium, sodium, uric acid, creatinine, liver function test, urine analysis, and 12-lead ECG. TSH can be done in a lot of cases, and now TSH or thyroid troubles are implicated in hypertension, implicated also in patients with heart failure. But echocardiography is not a basic testing. What is basic is doing a 12-lead ECG, which is important. A urine albumin creatinine ratio, which is more accurate by the nephrologist. They say this is better for detection of renal disease. A fundoscopy, something that we don't do, especially in those with grade 2 or grade 3 hypertension. Echo, we do it in our country because it's much cheaper than abroad. It's more available. I have a friend in Canada, and he might wait for an echocardiogram for 2 or 3 months for the waiting. Here in Egypt, it's much easier. So actually, echo is a good investigation in our country, but it's not essential. TSH, yes, like Professor Tamer said, is not essential in all cases of hypertension and more beneficial. So it's just understanding what people are thinking. Urine analysis is important. And this is our patient. You can see that he has a little elevation of his triglycerides, his LDL is in target, his glomerular filtration rate is good. This is calculated. He's pre-diabetic. Don't look at that because this is not diabetic. His urine albumin ratio, urine albumin is nil, but look at the ECG. This is an essential part, and this is the most important question, I think, like Professor Ashraf was discussing in the previous presentation. How to assess your patient. This patient, I remind you, is 57. He's a smoker, and he is hypertensive, 150/100, and he's just coming for shortness of breath. No cardiovascular problems, no other problems. Is this patient a low or an intermediate or a high or very high risk? Please vote.
Actually, this is very important question يا احمد. والحقيقه كلنا بنتلخبط فيه. يعني انا ساعات اقول على الحاله كده من اتس فيري هاي ريسك تطلع انها انترميديت او هاي. والعكس ساعات اقول انترميديت وتطلع فيري هاي. فالحقيقه انا انترستد ان اشوف الفوتنج هيقول ايه، وانترستد نشوف الاكسبلانيشن بتاعك وتقول لنا ايه البيست واي بقى ان اسيسنج ذا ريسك. ما نتلخبطش ان ده بيفرق في الديسيجن. ابدا علاج بدري ولا استنى شويه والتارجت بتاعي هيبقى ايه.
وحد ايه كمان بالظبط يا فندم، لان حضرتك you told us very elegantly that aspirin is not important for primary prevention nowadays, but statins, if the patient is very high risk or high risk, statins, this is another important part to assess our patient for benefits to other organs. Are we getting any results?
كده اذا كان عندنا، انا هشوف كده اذا كان عندي ما عنديش لسه. فيها معتز حاجه فوتنج سيستم ظهر. طب هيوصل لي الفوتنج اهو بنطلع النتيجه.
Professor Mohammed, are you with us? Mohammed Abdeshafi? You're muted.
تامر هو معنا.
Okay, Dr. Tamer, Professor Tamer.
ايوه.
What risk stratification tool do you usually use if you have a case with primary prevention?
يعني بتستخدم ريسك سكور معين يا تامر ولا؟
ايوه يا فندم.
معنا عبد الشافي دخل.
Okay, Dr. Abdeshaf. Yes, please.
The score risk system according to European Society of Cardiology.
Okay.
يعني هو هنا العيان ده مش very high risk, not very high risk.
Okay, agree.
سامعني يا دكتور اشرف؟ هو العيان ما عندوش.
جات لي نتائج يا عبد الشافي، جات لي نتائج. اكتر نسبه 33% بالتساوي انترميديت وهاي. 33 قالوا انترميديت و33 قالوا هاي. اللو 16% والفيري هاي 16%.
ده بيسموه في الام سي كيو a very good distractor. That means that we have تقريبا the same amount of amount. Professor Abdeshafi was talking. I'm sorry, Professor Mohammed, please.
ايوه فعلا. هو العيان زي ما حضرتك قلت 57 years old smoker, known to be hypertensive, looks like uncontrolled hypertension.
Yes.
يعني عنده two risk factors وعنده risk factor uncontrolled despite ان هو not diabetic وما عندوش اي evidence of coronary heart disease او cardiovascular disease او coronary. فبالتالي انا اعتبره I think for my opinion high risk.
التوتال كوليسترول كمان بيخش في الريسك ستراتيفيكيشن.
طب التوتال كوليسترول كام يا دكتور احمد؟
227
200 وحاجه
حاجه يعني كان عنده مالتي.
هو دي بقى الفكره. احنا we want to take a look. First of all, we should take risk on our patient. First of all, when you're talking about risk stratification and hypertension, you can use, of course, the score system. Excellent, very accurate. But if you are in doubt, you can just have this table, which is the European Society of Hypertension and Cardiology, having a simple way of blood pressure on the top and risk factors on the left. If our patient, actually, this patient is high risk, even if his cholesterol level is okay, even if his blood sugar is okay. Why is that? Because he has hypertension-mediated organ damage, which is the LVH. If a patient with hypertension has LVH, this patient is of high risk. If this patient did not have that or had one or two, yes, is moderate risk. Look at that. Anybody in grade 2 hypertension without even another risk factor is probably a moderate risk. Is there any data to support this? Yes. If you look at this score categories at high risk, you can see in the middle there, in those with high risk, it includes hypertensive left ventricular hypertrophy or CV elevation in grade 3 hypertension without another risk factor. So sometimes a patient may seem as very mild or moderate, and this patient is extremely high or high. And here, I think, like Professor Ashraf said, statins is very important, again, to control this patient. But yes, this is the patient we see a lot and we see is intermediate. So what is the target blood pressure? We want a quick vote. Montez, we don't want to take a long of time. So give us like 8 seconds for voting. What is the target? Thank you. And these targets, actually, I did not make them up. These targets are present in certain guidelines, certain associations. These are not made up. These are targets by certain associations for certain people. Yes. Yes.
I think it should be different according to the way of measuring blood pressure, whether it is office blood pressure or home blood pressure monitoring or ambulatory blood pressure.
Agree totally. Yes. If
I think we can consider office here as such in a case of clinical every day. So I think the office blood pressure is our target today. Okay.
Yes, keep us office because this is the one that is being targeted in trials like the SPRINT, like the ACCORD, like any other study. It is always the office blood pressure that has the data.
You can start to explain the results till I have some data.
Okay.
I have the poll now.
Please, Professor.
33% below 140/90 and 66% below 130/80.
Okay.
We prefer below 130/80.
It's good. Okay. 130/80 really actually started off in 2017 by the American guidelines saying all people should go below 130/80. And the European guidelines in 2018 agreed saying not to go below 120 or 70 for fear of hypoperfusion to the brain and heart. But those with chronic kidney disease or those very elderly, the European guidelines say we can keep them at 130 to 139, not to go below 130. So actually 130/80 is probably the one seen most. 140/90 was the target in the last European guidelines in 2013 and is still part of the NICE guidelines. I'm not sure anybody except the UK is going with the NICE guidelines. So I'll just ask a question. This patient comes to you and consider this patient is asymptomatic. Forget that he's symptomatic. Would you actually do follow-up? Just tell him, take care, reduce salt intake, reduce his body weight, maybe he's overweight, or from the first visit, would you prescribe a medication? Again, just 5 or 6 seconds, Montez, and we want to see what we are going to do.
I think this is very important question, Dr. Shawki, because this is the situation many of us face in the clinic or in daily practice. You have a patient and you have to take a decision whether to start the treatment now or wait for a while, and what to do while waiting if you don't choose to start the treatment. So there must be a clear cutoff points in this issue, because if you don't start treatment at the proper time, you expose your patient to a cardiovascular risk. And on the other hand, if you start the treatment while your patient is not in need for treatment, you may expose him to some side effects. So this is very important question, Dr. Ahmed, and I'm waiting your explanation. Actually, I will try to find if we have some results in the vote.
Dr. Ashraf, I think انه the patients البوردرلاين patients هم الموست difficult one، لانه definitely hypertensive او definitely normal دول straight forward مش هيكون فيهم اختلاف. انما البوردرلاين وسلايتلي elevated I think انه هيكون الفيصل ما بينهم risk stratification. البيشنتس اللي هم هينتموا للهاي ريسك جروب هم دول اللي هيحتاجوا initiate immediate treatment don't wait. طبعا هيكون apply life style modification all the time مع كل البيشنتس، ولكن to start treatment I think risk stratification هو اللي هيكون الفيصل، لانه اول ما يخش الجروب في الهاي ريسك I think to immediately start antihypertensive treatment.
Okay, and we have the result of the poll: 75% prescribe a medication.
Okay, I thank the 75%, and this is based on this evidence. If you have a patient, regardless of his blood pressure, if you have a grade 2 hypertension or grade 3 hypertension, regardless of the risk, you also treat from the start. And as Professor Ashraf elegantly put it, you are not just treating numbers, you are treating the risk of the patient. And Professor Temer just said that also, that we are trying to lower the cardiovascular risk. This cardiovascular risk is very important. So regardless of his blood pressure, if he's high or very high risk, you manage. And regardless of the risk, if he has grade 2 hypertension or grade 3, and he has grade 2 hypertension, that starts at 100 diastolic. So you go to the lower, to the higher one or the higher risk. This patient needs immediate drug therapy. And here also, again, this is just published a month ago, the International Society of Hypertension, talking about any grade 2 hypertension, immediate drug therapy is indicated as essential or optimal for the patients. So I think this is the final question. I will discuss a little bit after that. What would you give for this patient? Would you start with a diuretic, a RAS inhibitor, a calcium antagonist, or would you combine a patient with dual therapy from the start? This is a patient who has never had any medication. Of course, if Professor Ashraf, Professor Temer, Professor Mohammed, if you have any other drugs that you want to give, please tell me.
What was the blood pressure?
150, 100, sir.
Okay. So this is very important. You are starting with after repeated measurements with an average blood pressure of 150/100. So you should look at what do you expect from each drug of this to decrease. Can you reach below 140/90 or 130/80 easily with only one of them, or you should start with combination of 2 or even sometimes combination of 3. We have a high risk patients. We have a stage 2 This is stage 2, Ahmed?
Stage 2, sir. Yes, stage 2.
Stage 2 hypertension and high risk. I think I will consider at least combination of 2.
Very good.
يعني يا احمد برضو السؤال اصبح دلوقتي الموست ريكومنديشن فور الكومباينيشن. يبقى السؤال ده هو كان ستارت ويز مونوثيرابي بالانتي هايبرتنسيف. هم الجروبس 3 جروبس بس، الفيري الدرلي والناس الفيري مايلد هايبرتنسيف والفريل بيشنتس. هم دول الموست بيشنتس ان انا ريكومند ان انا ابتدي مونوثيرابي. انما يعني موست ريكومندد الكومبايند ثيرابي according to الجايد لاينز.
Yeah, this is a very good. Professor Ashraf, you're getting any data? I think I will.
And
go.
another important question, Ahmed, to decide
Please.
the treatment strategy, we ask ourselves whether our patient need a diuretic as a part of his regimen or not, according to the clinical picture, according to the examinations.
He's not edematous. He's not edematous. He has no strict indication for a diuretic, but of course, thiazide diuretics are also antihypertensives with good stroke prevention. Okay.
معلش هو كان اليوريك اسيد كام؟
اليوريك acid can normal.
Normal, yes.
Okay.
And so, while you are waiting for the result of the poll, you have, I think, the diuretic therapy is widely recommended by the GNC8 and the GNC7s, even at the first line treatment. Despite that, ARBs and the ACE inhibitor, I think, should be owing to their very high cardiovascular protection power, should be part of the therapy of any high cardiovascular risk patient.
Okay, until we see the poll, we're going to go and see what the European guidelines said.
Okay.
This data or this recommendation was built on data that the compliance or the targets reached in Europe is the same around most of Europe was not good enough. So they said, why not start with a dual combination therapy, a one pill that contains two drugs, either a RAS system inhibitor, a calcium antagonist, or a diuretic. Why these three? Because they're the ones with the best protection of the cardiovascular system. Beta blockers, perfect. We can use them if there is a strict indication, but their stroke prevention is inferior to these three. Of course, Professor Tamer said if you have a very frail or a very low patient with grade 1 hypertension or a very old patient, you might start monotherapy. But our patient is not that. And when you up titrate to triple combination. If you have it in a single pill, this is the best. Again, not all medications in the market, in the world, have a single pill with dual combination, very few with triple combination, and here data suggests that.
I have some result, Ahmed.
Please.
40% for ARBs and 40% for combination.
Okay.
20% thiazide, 0% calcium.
Okay, this is it's very interesting. What do the American guidelines say? The American guidelines say any stage 2 hypertension in the American guidelines is 140/90, which is stage 1 in the European. They say also initiate with a single pill with 2 medications. So they agree. They agree that we have to take combination. And what is also being said, was just published, again, step 1, low dose combination from the start. This is the International Society of Hypertension. But what is new in this guideline is something. The A is just the RAS inhibitors. The C is not verapamil or nifedipine. We're talking about giving the hydropyridines, amlodipine and felodipine, because the main data is for these medications, not for the medications which are verapamil and diltiazem and nifedipine. So this is the best. On the left, you can see what's called essential. If you have a patient with a myocardial infarction, of course, you can put a beta blocker. You can put other medications which are indicated. What here, again, combination, and they said a RAS inhibitor and C as one, then to up titrate the A and C, and preferably amlodipine and felodipine. Of course, amlodipine is more widely used. And combination therapy, C is always amlodipine. And then go to the triple therapy after you up titrate the the target 130/80. So this is a new slide to some of our trying to put steps on how to manage. And ideally, this is the most important in pill combination therapy. So what is the rationale? I'm not going to go to a vote here. Is it because they improve the control rates, or they improve the compliance or protection of the cardiovascular system? Actually, let's start about control. The problem in Europe, as in Egypt, the control rates is quite low. And the data we have from Egypt is around 8%. In Europe, it's around 50. In the United States, it's around 50, which is not good because we're talking about the number one killer as a risk factor. And if you look at this data from all over countries in Europe, especially Eastern Europe, the compliance rate is quite similar to us. It's around 20%. Maybe in the Czech Republic, because they are well educated and they have a very good medical service, it's around 50%. But this is the best. And these are the targets that were 140, not the 130/80. So here, again, compliance is important. And second of all, because of the cardiovascular protection, we should know that hypertension usually does not come alone. It could be coronary artery disease. Hypertrophy that we discussed is a high-risk category, can occur and can increase mortality. Stroke, chronic kidney disease, diabetes, as Professor Ashraf said in his take-home messages, are very important to take into consideration because they increase the morbidity and mortality. And finally, the compliance. Of course, more pills decreases compliance, less pills increases compliance. And these three were actually why the European Society of Cardiology, the American Hypertension Guidelines, and also the International Society of Hypertension Guidelines prefer a single pill as combination therapy. RAS, calcium antagonist, preferably amlodipine by the ISH, and diuretics. If you have dual or triple therapy, including that, then you are writing the best thing. And as you can see, of course, compliance goes with that. Not only does combination therapy improve compliance, there is a complementary mode of action for optimal blood pressure control and risk reduction, and it decreases blood pressure variability better than a single agent. Thus, another benefit of combination therapy is better stroke reduction. So I'm sorry to take a little bit of your time, but again, I want to assess hypertension is important because it's the number one risk factor. Risk stratification, we saw a patient, probably no complaints or just a little bit of shortness of breath, turned out to be high risk. And this is important. When you are going to treat these patients, you treat them immediately if they're high risk, regardless of their blood pressure. And if they're in their stage 2 or stage 3 hypertension, you give them therapy regardless of their risk. And here, by all guidelines, combination therapy is the most important. RAS system inhibitors, calcium antagonists, and now there is a preference to amlodipine and felodipine or dihydropyridines, and also diuretics, especially thiazide or thiazide-like. Monotherapy increased a little bit, but of course, combination therapy is number one. And thank you.
Thank you, Ahmed. I think Dr. Al-Shafi, Dr. Tamer, we have interactive discussion during the presentation of Dr. Ahmed. And I think it's time to conclude this excellent webinar. Thank you, Ahmed, for this case discussion, which is really guiding a lot of decision-making in our daily practice. And before I end, I want to thank ICOM company for the technical support, and I thank Novartis for the support of the CME activities of IAVA, and looking forward to see you all in our next CME waves and webinars. Thank you all. Goodbye and Ramadan Kareem.
Thank you.